Good morning. Hmm. All right. A brief one today. Final EP conference, I guess, of the year. Here we go. Okay. This is a tracing that one of the staff gave to me. Question is, what is this rhythm and how would you manage this? So why don't we ask Dr. Bezdakova what she thinks is going on here.
Morning, Dr. Pass.
Good morning.
Looking at this rhythm, it looks, just looking at it at the whole rhythm strip as a whole, it looks irregular. It looks like there's a P wave before every QRS. And then but the R to R interval does vary.
Okay.
Looking
Statement.
so looking at I'll just pick like V6 to look at the rhythm strip. Like at first beat, second beat, the third beat looks like a premature atrial contraction. And then it the it looks regular. And then there looks like a little run of 3 faster beats at a rate of 150. And it goes back to regular intervals again, and then we have
What do you
another.
make of those 3 beats, though?
Um,
Faster, I agree.
yeah, it looks like I would say like an ectopic um, atrial um, tachycardia. I don't know the age of this patient, but
Okay, so you have other leads you can look
yeah.
at to confirm that. So what do you think based on the other leads? Not disagreeing with you, but
Hmm.
proven. Because you said
Yeah,
you're only looking at V6, but I've been
yeah.
kind enough to give you all 12.
Yeah, and then and in the other leads, you don't really see the P waves as well. Um,
I don't know. I think I see
uh,
the end over
but
here. I mean, it's a crappy tracing. I'm sorry. I
yeah,
don't know why it's
it's okay.
projecting so bad. I think it's because it's such a big strip, but it's shrimping it down.
Yeah, I would say it looks like there's runs of EAT in this rhythm strip.
And what are you basing that on? I'm not disagreeing with you, but
Yeah, and basing it off, you know, where you have your pointer, that looks like a the P wave, but then the P wave morphology does change as you go on.
mhm,
In where you have your pointer right now.
right, as opposed to this beat, you mean.
Yeah,
And
yeah.
how do you know it's not what sometimes is called chaotic atrial rhythm? Another term would be multifocal atrial tachycardia. How do you know it's not that?
Hmm. I think because I you do see.
You're right, by the way. I'm just asking you how you would know it's not that.
Because where the P waves in multifocal atrial tachycardia look similar as to the intrinsic sinus P wave.
No. What happens in multifocal? What is what does it mean when it says
Or
multifocal?
that there's sorry, there's more than one one or two different P wave
Yeah, exactly.
morphologies.
There are multiple P-wave
Hmm.
morphologies. So in this case, because one of the reasons I gave you this long strip is so that you can
Yeah.
see that every time there are extra beats, like if you look in lead 2, every single time there's an extra beat, we have an inverted P wave that is seen just before the QRS. And it's clearly very different, right, than the sinus P waves, which are clearly very normal appearing. They're upright in lead F and 1 and in lead 2. But then every single time we have a fast beat, we have this inverted P wave here in lead 2, right?
Hmm.
If you look carefully, V6 is harder to tell, right? But if you
Yeah.
look carefully at V6, I think you can see also that, this P wave may have a similar polarity, but it's clearly different, right, than this P wave.
Yeah.
Whoops, I'm sorry. Clearly different than this P wave. So, okay, so this is multifocal atrial tachycardia. This patient is 6 years old, and they come into your office, and this is the very first time you've ever met this patient. So, what what are you going to do about this now? So you're there, you're in the clinic, and Robin says, "Boss, I did this EKG, and I saw there was some fast beats, so I ran this rhythm strip for you." And now you're walking into the room with the patient. So, uh, what do you want to know? Like, what are you going to what are you worried about?
Yeah.
What, what could you
I'm
worry?
worried, this is a 6-year old, so I wouldn't rely on their history in terms of like, are they feeling symptoms from this? So in terms of gauging how long that this
Yeah, I
has
mean,
been going on.
you could ask the question, but I agree with you that I wouldn't necessarily trust the 6-year-old's history. But yes,
And then, I would want to get an echo just to look at the function as an indicator of maybe how long this patient has been in it. Has the function been affected by,
right. So, in other words, you're worried that the patient may have a tachycardia-induced cardiomyopathy.
yes, correct.
Okay. And what else would you do now? So, okay, so you've done the echo, and the echo shows an ejection fraction of 59%. The LV looks okay. It's not
Hmm.
enlarged. So
Okay.
now you have this patient in front of you. What do you want to do about this, or in terms of
Um,
evaluating this?
yeah. Then I could place a ZO on the patient to see the degree of burden, how long that they're in this.
Yeah, you
Um,
definitely would want to do a ZO or a Barty or a Holter or some sort of
mhm.
ambulatory monitor to see how much tachycardia the patient has. Um, would you treat this in the office, or would you want to first see what's going on?
I would want to first see what's going on. If the
Would any
patient,
of the testing you've done change your mind in that regard? I agree with you. I would want to see how much there is.
I think, the EF being 59%, have a little room, at least to put on a Holter for a
Right. You don't
week,
have
maybe. Yeah.
at least right now, you don't have a cardiomyopathy. So that suggests that there isn't a, overwhelming burden of tachycardia
Hmm.
in this patient.
And
So,
then,
okay. So this patient did get a Holter or got a ZO, and
mhm.
I believe that the result was that something like 35% of all beats were ectopic atrial.
So then I'm glad we got the ZO and we have a baseline before starting treatment and like
Hmm.
a beta blocker like propranolol.
Yeah,
Um,
beta blocker's not unreasonable. What other options would you have? So let's
um,
say you put the
yeah.
child on the beta blocker, you repeat the ZO, and you're now at 29,000 PACs.
I wouldn't be happy that it only went down that little, and I'd want to add on another uh medication alternative in addition. So other options could be flecainide or amiodarone. Um, but
Any others?
um, other ones we could do
I agree with both
soda,
flecainide and
yeah,
amio, although
and
amio, it's not a great long-term
yeah,
solution, but
and then sodalol is
yeah,
another
Sotalol would
option.
be I mean, I think in this case, if someone didn't respond to something simple like a beta blocker, typically it would be either flecainide or Sotalol that
Uh-huh.
would go to treat this. And what's the disadvantage of these agents for the family, the patient?
Yeah, so when besides propranolol, if we're initiating any of the other options, we would have to admit them to the hospital for
Yeah,
telemetry monitoring
I,
as we
right.
start these medications.
I think that's right. I mean, there are countries where people do start these agents as outpatients, particularly in adult-sized patients. But I think in a 6-year-old where this would have to be a compounded medication, or at least actually Sodalol comes as a solution called Sodalize, and I think there may even be a generic version now that is appropriate for children. But I think in 2024, I think in most parts of the world, this would be started in the hospital in order to screen for proarrhythmia. Any other options that one could do to manage this? What would be the advantage of doing medical therapy versus, say, just taking the child for an ablation? Why would we not? I notice you did not recommend ablation. I'm not disagreeing with that decision, but I'm asking why? Why not an ablation, or what would be the potential benefit or the downside of doing an ablation at this time? Let's say the child is 20 kilos.
Um, so, I think with ablation, this a small size of a patient, 20 kilos, and then, the ablation catheters, and you can correct me if I'm wrong, but um, if the size of them might be like the sheet size might be a little too large for a patient of that size.
Well, I mean, what size is the sheath for balloon atrial septostomy in a newborn?
A 5 or 6, and then
Right, it's like a
yeah.
six, a 5 or 6, and ablation catheter is 7. So I think we could make the argument that a 7 French sheath in a 6-year-old is certainly no larger than a 6 French sheath in a newborn.
Hmm.
Um, I mean, I think the reason to consider not doing an ablation would only be that if it turned out that this was in the posterior septal region, that's an area that is particularly thin-walled, and so the risk of injuring a coronary might be higher in a small patient, where you could easily imagine that a thin-walled structure would be even more thin-walled in a small child than it would be in a larger child, although there have been reports of coronary injury in that area, even in larger children, and I myself had one many years ago. The other rationale, to me, the biggest rationale, though, would be simply that there's a chance it might stop on its own, and that one would avoid ablation entirely. I think at age 6, the chances that it's going to go away spontaneously are relatively low. Generally speaking, when it comes to automatic arrhythmias in children, the younger you are when you present with one, the more likely it is that it's going to spontaneously regress. So, for example, if we saw this in a newborn or in a child who's under 1 or 2 years of age, we would very aggressively try to medically manage this, not only because, as you suggest, the catheters would be challenging to place and carry more risk in a small child, and the procedure itself in a 2-year-old would probably be substantially more risk, I think, than in a 10 or 12-year-old, but also because there's a not insignificant chance it could resolve. By age 6, I think the chances are starting to get much more dim that it's going to go away. And I think that we're going to end up needing to ablate this, or one would need to ablate this. Interestingly, if you look at the morphology of the P wave, you see that in the inferior leads, it is negative, which suggests that it is actually posterior. And so it could be a posterior focus. And so it could actually potentially be a little bit higher risk vis-a-vis injury to coronaries. But if it was in that area, one could also consider using cryo, although the cryo catheter is an 8 French catheter and is very, very stiff. And sometimes just manipulating that catheter in that area in a small heart can result in at least transient heart block. So that's one of the reasons why most of you have seen us use cryo very infrequently. Maybe only one of you has ever seen us pull a cryo catheter in the entire last 3 years that you're fellows, because No, there's lots of reasons. It's technically challenging to integrate it into the Carto system, and we have to physically bring the console from another room, and the cabling is very short. There's like 100 reasons we don't love cryo. But one of the main reasons is because the catheter is very difficult to manipulate and it's very stiff. And interestingly enough, in almost every study of cryo, even though the risk of heart block, permanent heart block, is much lower with cryo, because we always talk about how the effect on the AV node can be reversible if you turn off cryo quickly enough, as opposed to RF, where even a few seconds can be a permanent problem. The incidence of transient heart block in almost every paper using cryo for the treatment of AVNRT, which is where it's mostly espoused in the literature, is much higher with cryo than it is with RF. That's because, first of all, people are a little bit more aggressive and willing to try freezing in areas that we might not be willing to try with RF. But I also think it's simply because the catheter is kind of big and bulky and unwieldy. And when you're moving it around the area of the triangle of Koch, it just sort of stands to reason that if you're moving a very stiff, difficult to manipulate catheter, that you might have more episodes of transient heart block. And that has certainly been my experience, although I've never, thankfully, had anyone have permanent block or even block that lasted more than 5 or 10 seconds. But it is frightening when it happens. So anyway, yeah, I think so in this particular case, the referring physician has started a beta blocker, and there is going to be a Zeo patch pending on that patient on beta blockade very soon. And then we will see what the result is and move forward from there. Any questions about that? All right. Why don't we move forward then? Okay, this is ventricular pacing. And the question being asked is, what's happening? And why don't we go to Dr. Mukhopadhyay? What do you think's going on here, Kentucky?
Good morning, Doctor. Good morning, Dr. Pass.
Morning. Thank you for coming in so early today on this brutally cold morning.
Um, uh, okay, so if I'm looking at the coronary sinus catheters, the initial deflections that I see are the ventricular depolarizations and
We're V-pacing.
yeah, and the following one is the atrial ones.
In other words, you're saying this is the V,
Yeah,
and this is the A.
yeah,
I agree with that statement.
and
So what happens as we go from this first beat on the left-hand side of the screen across?
I'm looking at the A waves, and I think the earliest one is in the distal CS.
So you're saying that, yeah, well, it's either distal or 3-4, right? It's one of these two. They're sort of on time, but you agree you're trying to suggest that these are earlier than these A's. Is that what you're saying?
Yeah, so that
Yeah,
means
I agree with that.
the pathway is like closer to where the distal 3-4, where the CS 3-4 is.
Uh-huh.
Um,
I agree with that statement. And so so this is just to rephrase that a little. This is so-called eccentric retrograde conduction. It's eccentric because the earliest A is not in the coronary sinus or the His pair. Of course, there is no His in this tracing. But it is eccentric because it's earliest in the left lateral position here. I might add the pathway was ultimately determined to be between pairs 3, 4, and distal, which would make sense based on this pattern here. Okay. So what happens as we go from the left side of the screen to the right?
Okay. So after the first two beats, I think the V waves, the ventricular, we lose the A waves, and then
Well,
yeah,
yes, there is no. So you're saying that there's no A following this V. Is that what you're saying?
yeah.
So we have VA, VA, V, no A. Okay. And then what happens in this beat?
We have the V waves, but the A waves are happening are occurring at an interval like very close to the V,
Uh-huh.
and then we have V waves, and then no A waves,
And
or
then
that
what?
they like the interval is very high if it's
So what do you think is, these are both A's. I agree with you. These are A's. What do you think these A's are? Are these retrograde A's? What happens in the atrium normally in human beings? What's going on electrically, activity wise in the atrium when we don't have a pathway and we're not pacing the V? When you get a 12 lead EKG, what rhythm are most patients in?
um like when we don't have a pathway,
What are you in? What rhythm are
like
you
like
presently
sinus
sitting?
rhythm,
You're in
like a
sinus
sinus.
rhythm,
Yeah,
right?
yeah,
So these are just sinus beats, right?
yeah.
These are just two sinus beats that are, and we notice there's no consistent relationship. Like in these two beats, right? There is a fairly consistent relationship between the V and the A. But in these beats, these are just sort of, here's a V, like this is not conducting, right, from V to A, because the V to A interval is like 30 milliseconds. There is no electrical tissue in the heart of human beings that can conduct this fast. So this is, and the other thing that's interesting is that the relationship of the A's to each other is a little earlier in CS proximal out to distal. In these beats going up the pathway, it's a completely different relationship, right? So these are sinus beats that are just sort of happening randomly at a relatively slow rate while you're pacing the V at a faster rate. The other interesting thing is if you notice this V to A interval is a little longer on this beat. Do you see that?
Yeah.
And then it's gone. This is actually an example of what we sometimes call catheter bump. So this is during the mapping, the catheter, we're moving the catheter around, and just the process of the catheter touching the endocardium where the accessory pathway is located, we have VA block from the just from the process of mapping. This is something that we do not like to see because sometimes the pathway will not come back. In other words, you may injure it just enough that during the time that the patient is on the table, there is no VA conduction through the accessory pathway. So if you see this, and now if RF current was being delivered at the moment that this happened, that would be a good sign. That would mean that we burned the pathway. But if RF current was not being delivered and we were just sort of moving the catheter around and mapping, then that's not so good because it means that that we've inadvertently injured the pathway without a burn. Now you might say, oh, but the pathway is not conducting. But generally speaking, if it goes away just from the touch of the catheter, the likelihood of it staying away permanently is pretty close to zero. So what we would normally do if this were to occur is we would pull the catheter away from this area. So in this case, we're transeptal with the ablation catheter. So we would put the catheter somewhere in the mid LA or maybe up towards the left upper pulmonary vein and just sort of sit there during the procedure, waiting for the pathway to recover so that we could continue to map. We would also at the same time look at the CARTO. So one of the big advantages of CARTO, which is a major advance, is that CARTO is recording everything continuously. And so with CARTO, we can actually see where the catheter was at precisely the moment that the pathway was no longer visible, meaning the pathway had been bumped. And so what I did was I asked our CARTO rep, whose name is Kelvin, to show me where it was when the catheter was here, when the pathway was still conducting, and where it was here when the pathway was gone. And the catheter really was essentially in the same exact location. And so now one could have just put the catheter into that location based on the CARTO map and burned there. But instead, what we did was we waited about 3 or 4 minutes, and the pathway came back, went back to that area, and determined that maybe a millimeter lateral to where it seemed to go away on the CARTO map was the better spot. You have to remember that we cannot tell where it went away between this beat and this beat. All we know is it was here on this beat and gone on this beat. But we don't really know if the catheter was maybe a millimeter to the left or the right, because it's also recording point by point on the CARTO map. But certainly the CARTO map can get us within 1 to 3 millimeters of the correct location. And, in the worst case scenario, you could at least go back and burn at, around that area with 2 or 3 applications and likely get the pathway. This is a major advance over the past. In the past, if the pathway were not to come back during the procedure while we were waiting, we would have to basically burn based on where we thought we were on fluoroscopy, which, as you could imagine, is not anywhere near as accurate as using CARTO, which claims to be accurate within 1 to 2 millimeters in terms of location. And that is one of the theoretical benefits of CARTO over its competitor, which is made by Abbott. There are other advantages to the other product that people like, with the most important being that you could use any ablation catheter with the other system. And so a lot of people don't like the CARTO ablation catheter. They find it stiff or difficult to manipulate. Some people like it. I myself like the CARTO catheters. Barry likes the catheters. Essentially, there are 2 types of ablation catheters. There are sort of stiff and not stiff catheters, and people generally tend to be like one or the other. It happens that both Barry and I trained in a center that used a lot of very stiff ablation catheters. So for us, using this catheter is not a big deal. And in fact, we prefer it. But a lot of places really hate that catheter, and that alone would be considered a rationale. One of the advantages of CARTO, though, is, as I said, it's a little bit more accurate, or at least it's claimed to be more accurate. Although I think people who use the other system would say that they've not found it to be difficult or a problem. All right, I think we'll stop here. Any questions about the case? So in actuality, we can actually see that the pathway, in real time, if we would have noticed that it was already getting longer before it went away. So really, the pathway was somewhere between where the catheter was at this location and where it is at this location. And it can be interesting on CARTO to see that catheter could be as much as 4 millimeters apart in these 2 locations. So that's why you really want to map it, not use CARTO to go back to the spot. It's nice to have the CARTO so that you can do something during the case if the pathway were not to come back, but really the preference is to wait until it comes back. Okay, I guess that's it for the day. Thanks, guys. Have a great day. See you guys a little bit later.
Thank you.
Thank you. Be well.